right, good evening, everybody. We're excited you could join the AO North America Link crew tonight. We're in our fourth session. We're talking about tibia fractures tonight. We're looking forward to discussing a lot of interesting cases, so let's get down to business here. Just a reminder, what is AO North America Link? It's a program geared towards our medical students in the field of orthopedics and throughout the AO network in veterinary, dental, you name it. So we're emphasizing four pillars: listening, integrating, networking, and knowledge, as we help you build that foundational knowledge to get you through your career and to serve you throughout. We really appreciate the support that we have for this initiative from Dr. Rout, the current AO North America president. Dr. Rout gave us some excellent advice when he tuned in a couple months ago. We're always excited to have Dr. Aker with us. Any words tonight, Dr. Aker?
No, I just want to thank all the participants for continuing to log in. We were collectively kicking around this idea for some education directed at the medical students, but we weren't really sure how much of a need or a want that there was. But month after month, y'all continue to surprise me and delight me that there's so much interest in coming back for this program. So thank you all very much for continuing to log in. But I also want to thank Ron and Beth and the whole crew at AO behind the scenes that helped make this happen. We couldn't do it without them. So thanks, everybody.
Perfect. So just a reminder, my name's Taylor Young. I'm an orthopedic trauma surgeon at Texas Tech University Health Science Center in El Paso, Texas. And Dr. Phil Mitchell, is my co-faculty tonight. He's at Vanderbilt University Medical Center. And we're really excited about our guests tonight. I might be a little biased, and I apologize to our former guests, but Dr. Elizabeth Harkin joins us tonight. She's the only guest so far who's won a World Cup. And so Dr. Harkin, we're really excited you could join us. Can you tell the audience about yourself and any piece of advice you have for our students?
Yeah, well, first of all, thanks for having me tonight. I'm very excited to be here. I'm in my third year of practice as an orthopedic trauma surgeon at the Medical College of Wisconsin in Milwaukee. And my small piece of advice for medical students as you're rotating on services right now and trying to stand out is, just find small ways to help support the other people around you on your team, whether that's gathering splint supplies, starting H&Ps, chart checking, things like that. Just those small things really help contribute to your team, make your residents look better, make everybody else look better around you, and really, helps you stand out.
For sure. Excellent advice. It's definitely a team sport, perhaps like US soccer. So we've covered a lot so far, and we're going to keep on trucking here. Tonight, we're talking about tibia fractures. Don't be afraid to ask questions. Keep that chat box, that Q&A box active. Dr. Mitchell's going to try to keep up with you guys. We really, really appreciate all the engagement, so keep it up. And reminder, don't forget to claim your badge for this session. You are going to be able to get individual badges per session. Even if you can't get that badge for all 10 sessions, collect as many as you can. And then don't forget to tune in after the fact. All of these lectures are on YouTube, and so you can go back, review. Maybe you didn't understand something. Don't be shy. Go back and watch those. A quick recap from last month. We talked about femur fractures. In particular, we discussed how we describe those injuries, mainly based on location. Our discussion was mainly focused on shaft and distal fractures. We talked about how we treat those injuries and how it's important to check the neck and check the knee after you treat those fractures. Because just like in this case, there was a femoral neck fracture identified at the time of insertion of the nail that did require an adjustment to the operative plan and required operative fixation of the femoral neck here. Don't forget, check the neck, check the knee. We also talked about the historical perspective with femur fractures. We went from all these crazy malunions to an era where we're using a lot of traction devices and these sorts of contraptions here. And then we evolved to the point where we're using really fancy nails, and it's really facilitated effective treatment of these fractures. We talked specifically about different types of nails that we use commonly. Here you can see two of those types: a piriformis entry nail, which enters at a start point that's in line with the shaft. So that's a straight nail going into the bone there. And then the trochanteric entry nail, which starts at the tip of the greater trochanter and that's more of a curved nail to facilitate use of that entry point. We also talked about a lot of the important technical aspects of nailing, how we use a reamer to engage the cortex, how we measure length, alignment, and rotation intraoperatively to match that for our patient in the treatment strategy. You can see here we used a intraoperative ruler to judge length, and we also used radiographic cues to identify the patient's rotation on their uninjured side and tried to match that with the nail in place using a perfect lateral at the knee where the femoral condyles are superimposed, and then a lesser trochanter profile proximally, and then match that to the other side. All the while, and throughout all of these talks, we've really emphasized leaning on those principles that guide us from our AO founding fathers here: anatomic reduction, or length alignment and rotation, obviously, stable internal fixation, preserving the soft tissue envelope, preserving blood supply, allowing patients early active mobilization. So tonight, the focus is tibia fractures. These represent really a spectrum of injuries. On the left, you can barely see a fracture. Trust me, there's one there. And then on the right, well, it's pretty obvious. That's a multifocal fracture, a lot of comminution, a knee dislocation. So the spectrum of injury is wide, and we'll try to cover as much as we can tonight. The objectives tonight are to classify and describe tibia fractures. We're also going to identify associated injuries that we commonly see and ones you really, really don't want to miss, and then understand some of the potential pitfalls that we might encounter when we treat these injuries. And we're really going to lean hard into the cases to emphasize a lot of these points and hopefully drive home the lessons. So first off, let's describe some fractures. When we talk about tibia fractures, we break it down by region of the bone in which the fracture has occurred. We talk about proximal fractures, some that may extend into the joint itself. Tibial plateau fractures, how we describe that sort of injury. And then we talk about the shaft and divide that into thirds: the proximal third, the middle third, and the distal third. And then we also have fractures that occur on the other end of the tibia, the distal aspect of the tibia, and may involve the joint surface of the ankle. We would call that a tibial plafond or a pilon type fracture. Those will actually save for our talk on ankle fractures. Tonight, we're going to focus on proximal fractures and shafts. So a throwback to the first month, we talked about how to describe x-rays. And so Dr. Mitchell had a really excellent systematic approach to describing an image. Here we can say, what is this image? It's two views of the tibia. The age of the patient is a skeletally mature patient. There's a fracture in the mid shaft of the tibia. It's a rather oblique fracture. One of the things to note is that the fracture itself is at a similar level to where the tibia fracture is in the fibula. And that gives us clues about the energy, the mechanism, and other associated injuries to look for. We don't really expect much extension of this fracture, and we'll talk about some of the related or associated injuries. As an aside, there's a little lesion in the bone there. We call that a non-ossifying fibroma. If you're interested, go read about it. It's not trauma, so we're not talking about it tonight. Case one, let's dive in. This is a 20-year-old male. He was involved in an ATV accident. Liz, can you tell us how you might have a student interpret this x-ray for you? And then what is your team doing? What are the students doing? What are the residents doing when they encounter this patient in the emergency room?
Sure. I love that structure that you gave to kind of evaluate x-rays. So thinking of it that way, this is an AP and lateral of the tibia in a skeletally mature patient. There's a fracture at the distal 1/3 of the tibia and fibular shafts at the same level. It's a short oblique kind of pattern. At a fracture at this kind of level, I don't necessarily see extension to the joint, but involvement of the posterior malleolus is something we always keep in mind as well. As we're initially working up this patient, we want to understand what is the neurovascular status of the patient. Obviously, if there's any open injuries, the skin anteriorly could be threatened just with the position that the leg is in right now. And so it'd be important to get him into a splint to help offload the soft tissues and get him ready for the operating room.
Yeah, those are all excellent points. One of the other things we might talk about is like x-rays at the joint above and below. Here, it's very rare well, I'm not going to throw too many stones, but don't let me incriminate myself. But we got a really good AP of the knee here. That's something to appreciate for sure. And you can see here the patella's in the midline. You note the appropriate overlap between the tibia and the fibula. The lateral aspect of the tibia may bisect that fibular head. And so this is actually a really nice AP of the knee. I just had to throw that in there. And then the patient comes in this splint from the outside hospital. So we're good. They're already splinted. Let's just book them for surgery maybe, and then they can hang out tonight, maybe go first case tomorrow. What would you have your residents do anything differently?
Yeah, I mean, we always have our residents take down splints and evaluate the soft tissue envelope. Particularly with the leaving the leg in this position can additionally threaten that skin anteriorly. You want to see if there's any fracture blisters or anything like that developing around the area. So we would definitely get them into a new splint in a better position.
For sure. That's what we did. And so you can see the alignment is improved. There's potentially less apex anterior deformity there. The splint, we put on a really nice, well padded splint, no open injuries. What do you think for this patient would be, as you start to talk about how you're going to address this injury, manage it, potentially with surgery? How do you talk to these patients about that option for treatment?
Sure. Yeah. I think, when you're talking to patients about operative versus non-operative treatment of tibia shaft fractures, one of the benefits of operative treatment is potentially weight bearing sooner, and not having to kind of deal with the cumbersome nature of a long leg splint or cast. So I would definitely, I guess, encourage this patient to pursue operative management. And my treatment of choice with this would be an intramedullary nail.
For sure. That's what we ended up doing in this case. Here you can see some of the important points related to tibial nailing. Like we talked about in the femur, the start site matters a lot as well. And so here you can see on this AP intraoperative view, there's a pretty good AP of the knee. You can see the fibular overlap is appropriate, and the starting point for that nail, or for that guide wire, excuse me, is right in between the two crests there. It's just medial to the lateral tibial spine on the AP view. On the lateral view, it's just anterior to that articular margin of the tibia, the joint surface of the tibia there. And you can see that, potentially I could have been a little more posterior, but it's a decent start site. And how do we get that wire in? Well, commonly I'm using a suprapatellar entry point. So an incision that lies just above the patella there. And then I work through a cannula that goes into the patellofemoral joint to establish that start site. There are certainly many other options for starting points. You can see in the diagram there's a infrapatellar or a parapatellar approach. What are you guys doing most frequently?
I'm typically doing suprapatellar nailing whenever possible. I definitely like the positioning for X-ray. I think is a little easier, and then just for supporting our clamps and things for doing our reduction.
I agree completely. Dr. Aker, are you doing mostly suprapatellar, or do you do a different semi-extended approach?
Yeah, so for me, the suprapatellar approach was a solution to a problem that I didn't really have other than very proximal third, proximal fourth fractures. The other way that we didn't really get into was the so-called infrapatellar nailing, which some of the students may have seen. You place the knee on a radiolucent triangle and you sort of flex up the knee or hyperflex it. And then you have a direct access adjacent to the patellar tendon, like the image on the bottom right there, into the tibia. The trouble is for very proximal fractures that you're trying to nail, when you put them on a triangle, it will necessarily flex or create an apex anterior procurvatum deformity at the fracture site because of the pull of the extensor mechanism. So for midshaft or distal fractures, I mean, I don't truly care, but if I'm doing the surgery start to finish, skin to skin, I do prefer the old school technique that's tried and true. For proximal fractures, I do love this technique.
Excellent. No, thanks for the perspective for sure. So as far as our suprapatellar nail goes and our infrapatellar nail, a lot of the concepts are similar. Here you can see we have inserted a ball tip guide wire after we utilized our entry reamer. The position of that guide wire is also important. You can see here on the AP view, it ends in the distal segment, sort of on the lateral third of the plafond or the talar dome there. And then on the lateral view, it's pretty much in the center. We were lucky this fracture was easily reduced with closed manipulation. The patient was young and had robust periosteum, but it is important to have a good reduction before you try to do these things. And then the nail goes in, it's inserted after reaming. And in this system, you're able to compress using the intrinsic features of the nail. And just wanted to point out that bent screw there, it's intentional, but it's part of that compression mechanism. So we've got good alignment, and then we let that patient walk immediately after surgery. So we'll dive into another quick case. This is
Hey, Taylor, can you just go
oh
back
yeah,
one,
yeah,
one
yeah,
slide? Just
for sure.
this is a common question for junior residents, and since a lot of the students are about to be there, I thought maybe we could get Big Phil in the game. I noticed here you did not address the fibula, and that's a common question. Like, when do you fix the fibula? Why didn't you fix it? Actually, a lot of my patients will be like a little upset. They're like, Doc, like, why didn't you fix the fibula? Like, it's lined up very nicely here, but Phil, can you explain to the students like when you might or might not fix a fibula that's associated with a tibia fracture?
Yeah, the majority of the time, I do not fix it. I think one thing you can do is to cover up the tibia and just look at the fibula, and sometimes that will determine if it's a fracture that I would fix. If I'm not going to fix it, if I cover the tibia up, then I won't fix it, even if we're nailing a tibia. So I think there are certain times you need to be aware. It can be, if it's a low fibula fracture, it may be acting like an ankle fracture. So if you fix a spiral tibia fracture and there's a distal fibula, you should assess the stability of the ankle mortise after that. And then there'll be a case in a few slides where it can be useful in cases where you're having issues with alignment or length of the tibia to fix the fibula. So I'd say probably 10% of the time I'm doing something to the fibula. The majority of the cases I'm not.
Thank you.
I think it's a useful cue too, to know how your reduction is in your tibia for sure. So this is another distal tibia fracture, a slightly different x-ray though. I want you to note a couple of important things here. The fracture in the tibia is a little bit different. It's not oblique, it's spiral in nature. And then if you see that fibula fracture like we just talked about, it's at a different level, it's higher up. So it suggests sort of a different mechanism, which is consistent with what happened to this patient, a 33-year-old female who fell down a hill and sustained a twisting injury there. And so it's a spiral fracture pattern. And Liz, in this kind of injury, what are you thinking? Are we gonna, how would you fix this one?
I would definitely try and use percutaneous clamps to get my reduction. And then this is typically an intramedullary nail for me as well.
Yeah, me too. And so actually, Dr. Mitchell opted to fix this with a plate and screws. A little bit atypical. It is the case that we highlighted last month as our teaser case. And so, Dr. Mitchell, can you tell us what made you think about fixing this with plates and screws rather than
Just make it very confusing mostly. No, so I think, and I'm really interested in Dr. Akers' perspective too. This patient, 33-year-old female, you know, in medical school, you learn to take the history. And so the history for these patients is also important what their occupation is. And so this young woman was a yoga instructor. So that's multiple yoga sessions, multiple times a day, doing positions that I have never been able to get into or hold for even more than a few seconds. But a lot of time with a bent knee, on the knee, those kind of things. So my concern with her was we nail her tibia and then she has knee pain from the nail that we've inserted. She's got a perfectly healed tibia, but she has knee pain that I can't figure out. So I did this minimally invasive plating, and I'm curious for maybe Dr. Aker, you've probably nailed more tibias than, I don't know, you're probably on the top 10 leaderboard in the country. What patients are you not offering a nail, or are you not suggesting intramedullary nail on?
Yeah, I got to say, I don't recall a yoga instructor, but probably a good 1/3. Yeah, about a third of my patients are laborers, blue collar, carpenters, mechanics on their knees, crawling in spaces, HVAC, heating, air conditioning. I haven't really shied away from a nail because of the potential for knee pain when kneeling. You know, we can go back and forth on the supra versus infrapatellar and the potential for more or less pain, but that this is a fair assessment, though, that I think it's realistic.
What about a 16-year-old soccer player, young woman who's maybe going to play in college?
Nail.
You'd nail her. Okay. Just
What
checking.
about a nail? What about a nail? Yeah, I just think that you can do a really, really nice operation on the tibia. You can try to compress it. You can diaphyseal tibia fractures with plates, in my experience, they're just not as predictable as with a nail. And if this does go on to non-union, you'll be kicking yourself and wishing she had a little bit of Advil to treat that knee pain on her 5th yoga session of the day. But if this works, then you've truly hit a grand slam and it's job well done. So this is a conversation with the patient. This is part of the informed consent process. So I applaud you for doing that, just that, and doing what she wished.
Yeah, so I think that's the point we really want to harp on, that a conversation with the patient is key. Shared decision making is key. And some of the things that help inform that discussion are studies like the SPRINT trial, which is one of our older multi-center studies that was sort of landmark in that nature and helped inform our discussion with patients when we talk about how long these fractures take to heal, as well as the incidence of knee pain, as well as potentially treating fractures that you can hardly see on x-ray non-operatively, because this patient had a fracture after hiking, did not want surgery, got a long leg splint, and was happy with that option. And so shared decision making is really key. The other thing we want to highlight tonight is associated injuries. When you have a spiral distal tibia fracture, we sort of touched on it quickly, that the risk of a posterior malfracture that you can identify with a CT scan is something important to think about. And so when you see this x-ray, you're asked to read it in a trauma conference, you say, oh, I want a CT scan to look for intra-articular extension. You're going to look pretty impressive. And you can see here, there's a faint line that extends into the tibial plafond. And so spiral distal tibia fracture, posterior malleolus extension. Just remember that. And so this does change the operative plan. So then we think about, we have to stabilize that articular injury first. There's a posterior malleolar fracture that we're going to fix with a partially threaded cannulated screw. We talked about this in month 2. This is a lag by design screw, which helps compress the joint prior to placing our nail. So that's a lot of info to cover, and we covered it pretty quickly, but we described tibia fractures. We talked about nailing and how to manage them, as well as the importance of an informed discussion with your patient, because there is some nuance to the treatment of these injuries, and then highlighting some of those associated injuries that we want to look out for as we manage them. So this is a 40-year-old male who had a open tibia fracture after a motorcycle collision. What are you thinking about with this injury, Liz? As this patient hits your emergency room, what are your residents doing? What are some of the important considerations as you're thinking about fixing this fracture?
Yeah, of course. Well, one of the things we harp on always with open fractures is making sure that the patient receives antibiotics and tetanus right away. You also, want to make sure we get a very good neurovascular exam and check their compartments, because certainly a patient, such as this would be at risk for compartment syndrome. As you kind of mentioned before, obviously getting appropriate x-rays of the joint above and below, and then getting him into good splint to take the pressure off of that soft tissue injury. We typically will use some irrigating solution just in the emergency department and betadine gauze to help cover that open wound underneath the splint until we can get them to the operating room. And then, in the time frame from splinting and stuff to getting them to the operating room, making sure that they're getting compartment checks.
Excellent. So Dr. Mitchell, you treated this one. We talked a little bit about the fibula fracture, and here you did opt to treat it. What sort of went into that decision? How are you judging length, alignment, and rotation in this comminuted fracture? It seems like it's probably tricky.
Yeah, I think you can contrast this tibia fracture with the first 2, which were more simple patterns. And this, you can tell, is a much more high energy type of tibia fracture. And for me, with it also being open, means a number of things. First, the risk of infection is higher, absolutely. And then the second, the risk of non-union is higher. So the risk of the bone not healing and the risk of infection. So first, we're going to do a good debridement to make sure the wound is not contaminated before we put our nail in, to make sure we don't have an infection. And then in this case, I use this flexible nail up the fibula for a couple of reasons. It was actually inserted before the tibial nail went in. It helped get our alignment for our tibia. And then additionally, it helped a little bit with rotation as well. And then I think I included this case because I was somewhat surprised that he healed uneventfully. He was a young guy, but that's such a highly comminuted short segment comminution. So comminution is a short segment of bone. A lot of energy through that region, a lot of soft tissue disruption. That this, I think, if I were to quote a non-union rate, I'd say at least 30%. But curious what others would do. Tim, anything different here? Any other thoughts on open tibia fractures, particularly distal open tibia fractures?
No, and I like the idea of fixing the fibula. Most importantly for me here is for soft tissue stability, because the more you have a fibula, or in this case, a segmental fibula, that's really just flopping around in the breeze every time the patient rolls over in bed, it's just really potentiating the soft tissue injury. And there's one thing that bacteria love more than dead tissue, it's instability. So I love the idea of fixing the fibula as well. This is a fantastic result for this guy. He doesn't know how close he was to having problems, amputation, etc. This is really phenomenal.
That's an excellent segue into a discussion on open fractures. We really wanted to highlight that the tibia is fairly subcutaneous along a good portion of its length. And so the risk of open fracture is high, like that last case we showed. This is a 23-year-old male who was involved in an MBC. He's in the OR with trauma surgery for an X-slap, and they call us. And so we see this. We're doing some of the same things that Dr. Harkin talked about in the ER. We're making sure they get appropriate antibiotics and tetanus, provisional IND, provisional stabilization, and then prompt debridement if they'll let us, and things like that. And so they're already in the OR, so we are going to try to capitalize on that. The other important things are thorough debridement, like Dr. Mitchell highlighted, and then really getting the bone covered as soon as possible. One of the ways we talk about open fractures, and something you might hear in some of the trauma conferences you sit in, is the classification system Castillo and Anderson. This is probably the most widely used for open fractures. And the basis for this system is the size of the wound to some degree, as well as contamination and the amount of energy imparted. One thing to note is there are 3 types, and then the third type is divided into subcategories based on the amount of soft tissue injury. Type 3A injury has sufficient soft tissue coverage. Type 3B injury requires intervention by plastic surgery in the form of a flap. And then a type 3C injury has a vascular injury accompanying the fracture and requires repair. But really the key point here is a thorough debridement and then irrigation. The solution to pollution is not dilution, it's a knife. And so we have to cut out all that dead tissue, all that contamination, and get a clean wound bed. This is that case that we talked about before. When we're seeing him in the OR, we get rid of all that dead tissue. We provisionally stabilize to prevent the ongoing tissue injury that Dr. Akers talked about. And in this case, I was staring right at the bone. I elected to do what we call a damage control plate. And this was later exchanged for an intramedullary nail and then covered with the assistance of our plastic surgery team. The other important thing to highlight in these in tibial shaft fractures is the risk for compartment syndrome, like Dr. Harkin mentioned before. This is a surgical emergency. A patient can lose their leg from this. They can develop a severe kidney injury. What it is an elevated pressure in a closed fascial space leading to tissue ischemia in the muscle. There are objective ways that we diagnose this with compartment pressures, but really it's a clinical diagnosis, and it's based on pain out of proportion, pain with passive stretch, and your clinical exam, because it's not always black and white. It's sometimes hard to discern. Do you guys measure compartment pressures, or is this a physical exam for you?
This is
100 patients
examination every time.
Yeah.
I think that's pretty common. And so you just got to be on the lookout for this thing, because it's a surgical emergency. how do we treat it? We let the muscle breathe. We make incisions in the leg, incisions in the fascia. One of the things you may get asked about is your anatomy. It's important to understand there are 4 compartments in the leg and knowing which muscles are in each compartment. So go make sure to study that, because you may get asked about it whenever you see one of these cases. Let's pause there real quick. Any good questions from the chat box that we need to cover as a group?
Yeah, perfect timing. So I'll ask Liz this one. What Asher asked, how often do you do compartment checks? So a patient comes in with a tibia fracture, you're concerned about compartment syndrome, or your resident is, how often do you want them checking that patient?
I usually tell our residents to try and check them every 4 hours at minimum. I think one of the most important things is to have a comparative exam. So especially if one of these patients comes in during a handoff period between the day and the night residents, I try and make sure that they go see that patient together so that they understand what the baseline exam for that patient is, because really the change in, pain or, pain out of proportion or pain with passive stretch is really what we're looking for, if they're developing a compartment syndrome overnight, so we can catch that early.
If they came in and they look like Ricky Bobby as he's running on fire around the track, would that be sooner than 4 hours in that case?
I might have a higher threshold, sure, for that one.
Yeah, or they come in biscuits and gravy, as we say in Tennessee, then yeah, we'll check them once overnight, see how things are going. So I think that's a really good question. One thing that comes up is we're working with our junior residents on call, document those exams as you're seeing them as well. So you want to put a note in the chart. And it is the trend, you're looking at how much pain medication you're getting. You're checking their compartments. You're checking how soft or how hard their compartment is, but you're also looking at other things in the chart and other things when you're talking to the patient. So I thought that was a great question. Another question about weight bearing of tibias. Do we progress them less quickly as we do with femoral shafts? I think it's really a case by case. We really try to get folks to weight bear as tolerated. But as you get more distal and more proximal to tibia, and as the bone quality decreases, the comminution increases, you may see that we keep folks off their leg a little bit, but we really try to get folks back on their feet. So again, going back to those principles, early active range of motion is one of the goals why we're doing these operations.
Excellent. Lots of good questions. Good to move on, you think?
Carry on.
All righty. So case 5, this is a 29-year-old male. It's a polytrauma involved in a motor vehicle collision. Just like prior, this patient's already in the OR with general surgery trauma. They're really on top of it. And so this patient has multiple open fractures. They're hypotensive. Massive transfusion protocol is initiated. So something's going on here. This patient's not doing super well. How does this change your approach to a patient like this? For the talk, we're focused on their left open segmental tibia fracture and does have a compartment syndrome, but there's a lot going on. How do you approach a patient like this, Liz?
Sure. So this is one of my partner's cases, and I thought was really interesting because obviously there's a lot to juggle here, right? You have multiple services involved and a patient who's essentially an extremis. So the goals here are really damage control orthopedics, right? So we debride our open fractures, address the compartment syndrome with fasciotomies emergently, and then trying to get our fractures at least out to the general length and alignment with an external fixator. And then you can see here the patient was again continued not to do well, so they had to use wet to dries and some combat gauze to at least just kind of address the soft tissue injuries until we could come back another time.
And what sort of timing, how do you decide when to come back?
Sure, yeah, so a lot of it depends on the patient's stability. So thankfully this is a young healthy guy who was able, after we kind of got him enough blood products and stabilized him in the SICU overnight, we were able to take him back to the operating room the following morning for more thorough debridement, extension of his X-fix, and then ultimately the fixation for his tibia, as you see here. Once addressing his femurs, was able to be treated, even though it was a segmental fracture. We were able to treat this with a nail and close his compartments primarily.
What are those little spots that we see on the X-ray there?
Sure. Yeah. So those are stimulant beads, or beads that are leach out antibiotics over time. So a lot of times we'll use that in open fractures that had contamination to help prevent the infection rate that we talked about before.
Excellent. Thanks for pointing that out. This is another one of the excellent cases that you submitted. This is a 22-year-old male who had multiple ballistic injuries and has an open wound there. What's a little bit different about this fracture compared to some of the other ones we talked about?
Sure. Yeah. So it's definitely getting a little bit more proximal in nature. So it's something to think about. You can also see on this view a bit better actually on the AP that there is a large kind of anterior extension that we want to make sure we address that doesn't displace any further.
Yeah, excellent. I think it's important to note, like Dr. Ager said, when you're doing infrapatellar nail, there are forces that are going to work against you. And in this case, the most common deformity that you'll get asked about in a proximal tibia fracture is valgus and apex anterior deformity, and that's mainly because of the patella as well as some of the other muscular attachments. And so we have to think about how we're going to mitigate them and what strategies we can use to do that. In this case, you really use a lot of interesting techniques, a lot of really skillful moves here. And so can you walk us through what you did here?
Sure. This is one technique that sometimes we reach for. It's called traveling traction. So you can see us placing a pin proximally. And we're really careful when we place this pin. We want to keep it out of our planned nail path. So we're kind of thinking a couple steps ahead. And then we'll place another pin distally in the tibia, again, out of our planned nail path for the end point of our nail. And what this does is helps hold our fracture out into appropriate length, alignment, and rotation. So we can really just focus on the nail and not really worrying about our reduction when we're kind of passing the nail.
Yeah, and this is just a little diagram that may sort of represent what something like that looks like. It's an incredibly useful tool. You used it really nicely here, but you also had to use other tricks to get this sort of tricky fracture to stay aligned, because really it wasn't super displaced, but certainly can displace in the act of fixing it.
Sure, yeah. Sometimes when fractures are kind of misbehaving, we have to kind of correct that. So we utilized blocking screws here to help prevent the deformities you kind of talked about earlier and help to guide the path of our nail.
Yeah, you can see here that Dr. Harkin put a screw somewhat posterior in the proximal segment and then lateral as well. You can see that based on the arrows here on both the AP and lateral views. Helped keep the tibia well aligned, mitigate some of those deforming forces. And really, in this case, I just want to harp on that idea. This can be a little bit confusing, even for residents and attendings alike. But blocking screws are supplementary screws. They are external to the intramedullary nail itself, and they help combat those deforming forces and help correct deformity. And so they're, I like to think about it as they're placed where you don't want the nail to go. Some people say they're placed on the concave side of the deformity, but you just have to be thoughtful in their application. In the proximal tibia, we're talking about a valgus and apex anterior deformity, or procurvatum, and that prevents, the lateral blocking screw prevents that valgus deformity, and then the posterior blocking screw prevents that procurvatum deformity. And so these are useful tricks that you need in your bag as you tackle these challenging fractures. Let's take another breath, because I know we're covering a lot of info. We're moving quick. We talked about open fractures. We talked about how to classify those with the Castillo and Anderson classification: type, not grade. Debridement and irrigation are critical. That's debridement more than irrigation. Antibiotics are essential. And then watching out for emergencies, compartment syndromes. Can't miss that. Patients will lose their legs. And then being thoughtful in how we treat tricky fractures and mitigate deforming forces in the proximal tibia. Any good questions popping up, Phil?
Yeah, a couple of things. First, just in terms of blocking screws, you're going to see those most commonly when you're in a case when it's a proximal tibia, so a high tibia fracture. The rod goes in and the fracture displaces. So it was reduced and then it no longer is in a good alignment. And then that is most commonly when you'll see that technique utilized to have screws put the nail in a different location within the bone to help maintain alignment. So it's more uncommon to see them kind of placed initially and then the rod goes in. It's typically you put the rod down ooh, that didn't do what we thought it was going to do. Let's use these screws to put the nail in a different location in the bone. One, Henry asked, how long do you leave the fascia open for a compartment release? And I thought that was a pretty interesting question, because typically when we release the fascia after a compartment syndrome, that fascia ain't closing no mo. So it's typically at that point we're getting skin coverage, and that's going to be anywhere from 2 to we'll say 14 days. They're going to get skin grafted depending on the situation, the clinical situation, the patient, availability of a provider who's going to do a skin graft. Some orthopedic surgeons are comfortable skin grafting. Some are too busy to skin graft. So they're going to have their plastic surgeon help with them, work with them to get that done. So, and then Dominic, future probably orthopedic trauma surgeon here, the screws on the damage control plate, he said they were a little short, Taylor, and made the great comment that, was that leaving room for a nail after you put the plate on the bone? And I thought that was a nice observation that he made there. So, and also just something to bring up to the group. So I think otherwise we're good to proceed.
Love it. Love the engagement. Keep it up. Interproximal fractures, particularly focused on tibial plateaus here. Just quickly, these can be extra-articular fractures, but more commonly in this case, we're talking about partial articulars or type B injuries. We touched on this in prior lectures. This is a B-type injury that's often going to be treated with a buttressing implant to compress the articular surface. And they can also be complete articular injuries where the shaft is completely disconnected from the articular surface. Dr. Schatzker is a living legend in the realm of orthopedics. I would bet there's probably not a question asked more commonly in trauma conferences about a classification scheme than the Schatzker classification. So it's certainly one I would recommend and dive into the literature and look at the original article. A type 1 injury is a lateral split. A type 2 injury is a split depression. A type 3 is a depression alone. A type 4 is a medial plateau injury. A type 5, some people might say, do they exist? But it's a bicondylar injury without metaphyseal, diaphyseal dissociation, or meaning the shaft is still in some way connected to the articular surface. And then a type 6 injury is a bicondylar variant where the shaft is not connected to the joint at all. So case 7, this is a pretty simple fracture here. I'm just going to run through it quickly. Late 20s male, he hurt his knee while playing soccer. We can run through the Walter here, but we'll just be quick. It's a lateral split depression injury. It's an articular injury, so we're going to need a CT scan to see what's going on there. But one of the associated injuries you want to watch out for is a lateral meniscus injury, where that depression is. We get CT scans in these injuries to understand how much depression you might see there and define where that split is on an axial view to help make your surgical plan. Intraoperatively, we often use the contralateral side like we did in the femur for templating, and then you can see here we used a distractor once more to help expose the articular surface and get a good view. And we looked for a meniscal injury by performing an arthrotomy, and then we fixed the fracture with a buttressing implant like we talked before. That axillary screw helps us compress the plate, and then we wrapped and support the articular surface and match that other side. You can see it on the lateral view here. And then let's dive into a slightly more interesting, a little bit more complex case. This is a 47-year-old patient who sustained an injury after skiing. Phil, you submitted this case. I suspect they sustained this injury because they're trying to ski in Nashville.
That's correct. I should have highlighted water skiing.
Oh, water skiing. Excuse me. So this is a different sort of variant of the plateau fracture. If you classified it by the Schatzker scheme, Liz, what is this fracture pattern, and what sort of alarm bells are going off in your head?
Yeah, so with this medial tibial plateau fracture, one of the things we really have to be concerned about is a neurovascular injury. And so that's kind of high up on our list when we see these initial injury x-rays, that we want to make sure that we get a good exam and rule that out in this patient.
Yeah, excellent. That's a really important point to note. Like one of the associated injuries we want to highlight with these sorts of injuries are vascular injuries. And so we want a thorough vascular exam in the ER, and that probably includes looking at a patient's ankle brachial index or a ratio of their ankle blood pressure to their brachial blood pressure. And the importance of this is that the vascular anatomy of the lower leg, the popliteal artery, has an intimate relationship with the posterior aspect of the tibia. Important to do the ABIs in this setting by recording blood pressures, getting that ratio. A normal ratio is 0.9 to 1.1. So, and it should be similar across both sides. If it's not, that should set off alarm bells. In this patient, it was not. And so then the next step was a CT angiogram to look at the integrity of that vessel. You can see there's some cutoff here on this scan. And so there is a vascular injury, and that changes a bit what we do here. But ultimately, we talked to our vascular surgeons to assist us with the management of that injury. And then still a type B injury or a partial articular fracture gets a buttress plate on the medial surface to compress the articular surface. And then the patient is able to move on with their life, hopefully keeping their leg, because we identified that injury early rather than missing it, potentially leading to loss of limb and other complications that can be devastating.
Taylor, will you go back 2 slides? Sorry.
For sure.
I really want to highlight this case, even go back one more, and one more.
Sorry.
It's such a surprise that this fracture, which to my eye, in terms of severity, doesn't look that bad. To some of the other ones that you showed, where there's a tremendous amount of comminution. It's like if I was looking at this across the room, I could barely even see it. So I want to highlight in the Schatzker 4, in the medial tibial plateau, it may look innocuous. It may not look terrible, but your antenna should be up for all those. And so all those patients should be treated as if they have a presumed vascular injury. And one of the biggest transitions when y'all become residents is the onus will be on you in the ER to decide if this patient with this fracture that doesn't look that bad has a vascular injury, and how they do is going to be dependent on your ability to assess their ABI. So I think this is just a really interesting case, and one that certainly I'm using a lot to teach our residents, because somebody did a great ABI and picked it up. We got a CTA, and again, I was a little bit surprised. Tim, any other thoughts or input on these types of fractures and identifying these injuries?
A lot of times, I mean, it sounds a bit condescending, but I think the orthopedic house staff literally are the smartest folks in the hospital overnight. Like, I'm not exaggerating. They're the smartest folks. And so, seek disease. This guy's got a leg because someone had the wherewithal to say, you know what? I'm going to do ABIs. It takes 2.5 minutes, and I'm going to do it real quick. And then they were less than 0.9. And so you bump it up, and next thing you know, you're saving a leg. So I love the idea of, the orthopedic house staff that these students are about to become, to really take the bull by the horns and be confident in your abilities to treat and diagnose injuries and bump it up. And when you get pushback from the ER attending, you don't need that test. Why are you ordering that? Just stand your ground and have a reason why you're performing these exams, and you might save a life and save a leg. You never know.
It's wonderful to have a number, and instead of, I feel like everybody gets a CTA except for this person, because their foot looked blue, or their foot felt a little cold, or there were asymmetric pulses. It's like you have the power to do this test, which gets a very objective number to then make a diagnosis. So anyway, out of that case, again, burn it. Every Schatzker 4, that vascular injury unless proven otherwise.
Excellent points for sure. Another associated injury that, just like the vascular injury, very severe, like we talked about in shafts, in proximal tibia fractures, Schatzker 6 type injuries, metaphyseal, diaphyseal dissociation, high energy injuries should start to set off those alarm bells once more. You got to be checking those patients, like Dr. Harkin said, overnight for compartments. And if a leg starts to look like this, you want to check on that patient and understand what's going on there. And so important to note the association with Schatzker 6 injuries and compartment syndrome as well. This patient did get a 4-compartment fasciotomy through a lateral incision, and ultimately needed a skin graft with our plastic surgery colleagues as well. So another breather. We talked about a lot of stuff here, a lot of really, really important points, a lot of things you don't want to miss because they could have devastating consequences for your patients. But important to note the Schatzker classification, all the associated injuries that we do see with those type of fractures, less significant but not unimportant. Meniscal injuries, we're not sports surgeons, but we have to look for those. And then vascular injury and compartment syndrome, those are the big red flags that we want you to be aware of. We want you to, like Dr. Ager said, seek disease. When you see those subtle clues, save a patient's leg, help the patient for sure. All right, let's
I
dive
got one
into.
question real quick,
Oh,
Taylor.
yeah. Sorry.
Yeah, I think this is a really good question, and it's commonly multidisciplinary conferences every year, us and vascular. How urgent do these patients need to be placed in an X-fix with vascular injury overnight or the next morning? Wonderful question. Very complicated in some ways, but most commonly you'll see typically orthopedics will place them in an external fixer device followed by vascular repair after that. Okay, so that's the most common that you'll see. But in this case, vascular did the repair because it was a length stable, so we didn't need to use an external fixed device. Length stable situation, they did the repair, and then the next day we fixed their tibia. So a little bit case dependent. And the second question I just want to highlight from Cesar, in ballistic injury, since they're considered open fractures, why don't you remove all the projectiles in the initial IND? I think you'll see a lot of different management styles. I think if it's easily accessible right there in the wound, the bullet's coming out. If it's going to be a fishing expedition, if I'm going to be watching a resident under fluoro with 200 shots trying to get a bullet out, we're probably going to leave it. So, Tim, how has your practice evolved? Has it changed at all for ballistic injuries? Are you more aggressive or less aggressive going after bullets than you were 10 years ago?
Yeah, I would not say that I'm aggressive going after bullets. For me, ballistic injuries, no two are the same. It's completely dependent upon the amount of gunpowder in the bullet, high velocity round, low velocity. What does the soft tissue injury look like? A very low velocity handgun that has a very simple tibia fracture is probably going to get a very minimal local IND of the entrance wound or entrance and exit wound, as opposed to a shotgun blast or a rifle that really leaves a hole this big in the back of the leg. That's a different story. I mean, the soft tissue injury for me really dictates how aggressive the debridement is.
Great points. Thanks for highlighting those questions, Phil. We're going to dive into some cases to close things out a bit. This is a really, really interesting case. So this is a 47-year-old male, had a motorcycle collision and has some leg pain, probably because they got this fracture here. They have a little bit going on. They have some past medical history that may be significant in terms of how we decide to manage this patient. There are no open wounds, but there's starting to be some blisters there. How did this affect your decision making in treating this case, Liz?
Yeah, so anytime people start to present with fracture blisters, you really want to pay attention to that soft tissue envelope, as we've been emphasizing. So if possible, I'd like to treat this with a nail in order to minimize the damage to that soft tissue envelope, inflicted by me.
Yeah, for sure. I mean, looked like a fracture ripe for nailing, but there's a total knee here I guess we can't nail it then because the total knee is blocking us from nailing it. Is that a correct assumption that one might make?
I think that's always kind of the gut, reaction, is that you can't nail this fracture because of the total knee implant. But I think one of the really helpful things is that really nice lateral of the knee there. And I think that really helps to show us that there is some bone anterior to that, to the keel of the implant, and we can still take advantage of that to place a nail.
It seems challenging. Can you talk to us a little bit how you might accomplish that?
Yeah, so I mean, I think one of the important things here, we did use an infrapatellar approach for this particular case, and just being very precise in using our starting guide wire and our opening reamer there. Obviously, I'm carefully using this reamer because I want to make sure we're also not knocking off their tubercle, which is really important to make sure they're not disrupting their extensor mechanism. And then once we get a nice starting reamer there, we want to make sure that our guide wire doesn't continue to aim directly posterior to posterior cortex of the proximal segment. So we want to make sure that we can get down into the shaft appropriately.
Any other tips for nailing below a total knee, Dr. Aker?
Taylor, if you can go back one slide, this is a really interesting point here, because a lot of times the medical students about to be interns, they're on the front lines and they're the ones putting these splints on in the ER. Take a look at image number 2 and look how long the short leg splint is digging into the popliteal fossa. If it doesn't give the patient a foot drop, if it doesn't give them vascular compromise, it's at least going to leave an ulcer in the back if the leg stays flexed like this. So just, these are like the devils in the details, subtle little things at their stage. These are splints that MS3s and 4s are applying. You have to be cognizant of how long to make your splints. This could be potentially catastrophic if this patient is obtunded and she goes to the ICU for a couple days. No one's checking on the vascular status. Meanwhile, there's no flow to the leg for 2 days, so really just devils in the details. That's all.
No, excellent. Thank you for pointing that out. But do you also have any tips for nailing or doing a tibial nail in the presence of a total knee replacement?
I think in general, all of Liz's points are absolutely true. For the most part, most simple primary total knees are nailable. For a while there, a lot of us were scared. But as the time went on, as I mentioned earlier, plating of diaphyseal tibia fractures can be done. It's just not as reliable and successful as nails. So yeah, this is a little bit of the art and science of orthopedics, taking some measurements, making sure that you can first do no harm and safely nail this tibia, which Liz did a very nice job with here.
Thanks, guys. So I'm just going to fly through this last case pretty quick in the interest of time, so we can still have some room for some questions, maybe clarify some final points. This is a 20-year-old female who fell off the international border wall. She has a combined injury. You see a medial plateau and a shaft here. She had increasing pain, and this is where that exam is really important. She had already had a CTA ordered by the trauma team. She did not have a vascular injury, but she did have compartment syndrome. She gets compartment releases. The muscle's nice and healthy. Important to evaluate the muscle there. And then we look at the articular injury in the presence of a compartment syndrome with a big open incision that was, we were luckily able to close without needing a skin graft or anything, but it might be nice to avoid a lot of plates and screws in that setting. And so then we're able to fix the joint surface and then place a nail and treat both injuries at the same time there. And then just want to highlight, next month, we're talking about hip fractures. And this is a nice little teaser case here to get the brain going. This is certainly an interesting fracture that Dr. Mitchell is going to tell us how he tackled this one. So thanks so much for tuning in. Don't forget to collect that badge. Remember, individual badges per session. And then watch the videos on YouTube to kind of iron out some of those important points. Don't forget to check out the OSAP platform. And thanks so much to Dr. Harkin for joining us. We really appreciate you coming on. And we just want to see if anybody has any last minute questions, any important points you guys want to talk about that maybe we gloss over. I know it was going fast. I just get enthusiastic talking about all these great cases.
One question to bring up. So when placing the nail in such close proximity to the tibial implant in the total knee case, is there an increased incidence of periprosthetic fractures or implant lucency? So I think that's a great question. I think if we got a room of total joint surgeons and we showed what we were doing around some of these total knees, they'd have some strong opinions, but no literature bears that out that this would change implant lucency or have any impact on that. And then in terms of periprosthetic fractures, it's somewhat dependent on the fracture itself. So the image, that lateral view that was shown of that particular tibia fracture, there was a fair amount of bone anterior to that tibial component, but sometimes it's not as big there. And so if you're really pushing the limits, you may, yes, be at risk of fracturing off a tibial tubercle if you're being a little bit aggressive with your nailing. So any other points related to that, Liz, Taylor, or Tim?
No, I think you covered the bulk of it there.
I just wanted to say that just for completeness sake, that a lot of the med students will be down in the trauma bay with the interns and the junior residents consenting patients that have closed diaphyseal tibia fractures. And I will say that for hundreds, if not thousands of years, we've been treating tibia fractures with splints and casts and non-operative means. Tibias will heal without surgery. Without a doubt, you can get a tibia to heal without surgery. And so part of the informed consent process is like we started to allude to earlier, with 6 weeks of a long leg cast, 6 weeks of a short leg cast, all the while non-weight bearing, all the while taking plenty of x-rays to make sure the alignment is maintained. It can be done, but it's very labor intensive. And most patients would much rather not have all of the immobilization devices, and they'd all like to walk a little sooner. But that's one of the big things in Houston that we really harp on the residents, that you have to at least give them the option. Like sometimes patients think like, well, I broke my leg, I have to have surgery. It's really dealer's choice. Like you have to be given all the options to make an informed consent decision. I agree with all of the decisions that were made here. I think surgery is good. Steel to heal, Taylor, steel to heal, or titanium to heal in some cases. But I just want to remind the students that not all tibias need a nail at all times. That's all.
No, that's a really important point for sure. Yeah. Because patients have to accept the risks of surgery too, you know. It's not there are pros and cons to everything we do in medicine. Well, thanks so
Awesome.
much, everybody. Really appreciate all the excellent input and all the great cases. Hopefully, everybody learned a lot. We hope to see you next month for hip fractures. We're really excited to talk more as we work through our curriculum here.
Thanks, everybody.